follow along with the conversation in either Spanish or French, you can click down at the bottom of the screen, the globe icon that says interpretation, and you can choose your preferred language. You'll also have the option to hear the English softly in the background or just hear the preferred language. And we appreciate the support of our interpreters. We're also happy to have and grateful to have the support of American Sign Language interpretation services today as well. So thank you very much. So we've had over 1,300 people register for today's session, and we're grateful for the time that you've taken out of your busy schedules to join us. I'll be co-facilitating today's session with the director and founder of Project ECHO, Dr. Sanjeev Arora. Sanjeev?
Hello, good morning and good evening. Welcome to all of you. Really honored to host this session along with the World Health Organization to address one of the most important issues that is confronting humanity today, and that is how are we going to ensure equitable distribution of the vaccine. And thank you to all the speakers who've chosen to join us today.
Great, thank you, Sanjeev. And before we begin, we do want to address some housekeeping items. So today's session, as usual, will be recorded, and you'll be able to find links to the video within about 48 hours. They'll be posted on our website. So please look to the chat box for a link to our webpage if you'd like to look out for the video for today's session, but also look at videos from past global learning collaboratives and global conversation series around COVID-19. Please note that today all of the participants will be in listen-only mode. If you would like to submit a question today, and we certainly encourage you to, please submit them in the Q&A box at the bottom of the screen. And we'll ask that you refrain from responding to other people's questions in the Q&A, please. Also keep an eye on the chat box as we go, because as you're already seeing, there will be a number of resource links posted there by the ECHO Digital Librarian. And as you can see here at the end of the session, we will also be posting a link for a survey that you can complete to obtain your CME credit and CEU credit. And so before we begin with the presentations, I'd like to have our panelists introduce themselves. Let's see, is Dr. I'm gonna switch my view here. Is Dr. Swaminathan? Hi, Dr. Swaminathan, go ahead and introduce yourself. Welcome.
Yes, hello, thanks, Matthew. I'm Soumya Swaminathan. I'm the Chief Scientist at the World Health Organization.
Thank you, Dr. Swaminathan. How about Dr. Hanal Restrepo?
Good morning, good afternoon, good evening. My name is Ana Maria Henao Restrepo, and I am the co-lead of the Research and Development Blueprint, an initiative to conduct and prepare for research during epidemics and pandemics.
All right, welcome. How about Dr. Lindstrand? And I'm just checking, we'll come back. I think Dr. Lindstrand may have temporarily dropped off the network. How about Dr. Mihigo?
Yes, thank you. Good morning, good afternoon, depending on where you are following this webinar. My name is Richard Mihigo. I work for the World Health Organization in the Africa Regional Office. I'm the coordinator for immunization and vaccine development program at the regional office.
Thank you, Dr. Mihigo. How about Sani Wendis? Go ahead and introduce yourself and welcome.
Hello, everyone. My name is Sani Wendis, and I am the lead of the design and operationalization team of the Office of the COVAX facility within Gavi. Very nice to be part of this panel this afternoon. Thank you.
Likewise. All right. Thank you. And let's see, is Dr. Lindstrand with us?
Hi, Matt, I think she may have, I think she just joined.
Wonderful. Give Dr. Lindstrand.
Anne, are you able to hear us? Can you introduce yourself? I think she was having difficulties with her connection. So maybe we should go ahead.
Yeah, at the moment she's muted, but I do see that she has jumped back on the network, which is great. All right, well, we will begin today's session with two presentations from Dr. Swaminathan and Dr. Henao Restrepo. And then this will be followed by a moderated Q&A session. So again, please keep your questions coming, submit them in the Q&A box. We also have a number of questions that we received during the pre-registration. So we'll get through as many of those as we can as well, and thank you. Dr. Soumya Swaminathan, I would like to introduce first, is Chief Scientist of the World Health Organization in Geneva, Switzerland, and she's an Indian pediatrician and clinical scientist known for her research on tuberculosis. Dr. Swaminathan has been Chief Scientist of the World Health Organization since March 2019, and prior to that was the Deputy Director General of programs at the World Health Organization. Dr. Swaminathan holds MBBS holds an MBBS from the Armed Forces Medical College and MD from the All India Institute of Medical Sciences in New Delhi, along with a Diplomat of National Board from National Board of Examinations. She subsequently held her postdoctoral medical fellowship in pediatric pulmonology at the Children's Hospital in Los Angeles, California, Keck School of Medicine at the University of South California. Our second presenter will be Dr. Henao Restrepo, who is currently the team leader for implementation research at IVR. Among other issues, Dr. Henao Restrepo is responsible for a project to review the evidence and inform the development of adjusted policy recommendations, recommendations for vaccines currently in use in the immunization program. She has also led a project to develop and assess a measles aerosol vaccine. Dr. Henao Restrepo has also contributed to the expanded program of immunization and served as the World Health Organization global focal point for the measles and rubella control efforts between 1999 and 2002. So without further ado, over to you, Dr. Swaminathan.
Thank you. Can you see my screen?
Yes, we can.
Okay, so I'd like to do a brief overview of the epidemiology and talk a little bit about the issues that we're facing now globally, and then Anna Maria will continue with some of the research priorities and knowledge gaps that we have. So as we can see, the pandemic continues to grow at a rapid rate. In the last week, we had over 3.5 million new cases. In fact, in the last 2 weeks, we've had more new cases being reported worldwide than in the first 6 months of the pandemic. And 93,000 deaths. And cumulatively, we've crossed 100 million and 2.2 million deaths globally. The Americas and Europe still, the majority of infections and deaths occurring in these two regions. But in the last week to 10 days, there has been a decline. At least it's starting to plateau and come down. And that's probably the response to all the stringent measures that countries have put in place. And you can see on this slide also the countries which have the largest number of cases, the trajectory on which they are, and as well as the number of deaths and the cases per million population. This actually is the same thing, but it's showing you the deaths that are reported by per million population, and the darker the color, the higher the number of deaths. And again, it's North and South America and Europe, as well as Southern Africa, that are disproportionately affected. Now, this one is a slide that shows the spread of the variant 2020-01-12-01. It's also called B117. We don't want to call it the UK variant because we're trying to avoid naming countries or stigmatizing countries just because the variant was first reported there. But you can see now that this variant has been detected in over 70 countries and the number is increasing. And the big gap you see in Africa is because of the lack of sequencing capacity. And the number of sequences obviously from Africa are much lower than the rest of large parts of the world. Similarly, we see that the 501YV2 variant, also called B128, I think, which is the South Africa variant, which has the same 501 mutation, but in addition, it has other mutations like the E484K, which are very worrying because they're on the spike protein just at the point where the antibodies bind. And therefore, these strains not only are more transmissible, but also appear to have some resistance to the neutralizing antibodies that are generated based on infection with the wild type strain, and as well as some vaccines. And we can come to that a little bit more in the discussion. So again, over 30 countries currently reporting the presence of the South African strain. And in the UK, they've just reported cases which had no history of travel, which means that there's some community transmission already. Now, all this is not surprising. You know, we knew that viruses will mutate, that they will change. We've been tracking it. The database GISAID has over 400,000 whole genome sequences currently from over 120 countries. So one great thing during this pandemic has been the fact that, you know, countries have not only sequenced, but have shared in a public database sequences so that scientists all over the world can study the evolution of this virus and also study what impact it's having both on transmission and clinical severity, as well as on the new tools. And this is the P1 variant first reported in Brazil, in the Manaus region, also in Japan, from people who travel there. But you can see again, there are already several countries, about 10, that are reporting this variant. Again, the more you look, the more you will find. Again, this variant is concerning because it has the same E484K mutation, plus a combination of other mutations which might be contributing to increased transmission. We're still waiting for experiments on its impact on clinical severity and on vaccines. So as I said, why is it important to monitor these variants? It's clear that variants many of the mutations which occur in viruses have no impact at all. Some of them are actually detrimental to the virus, but the virus tries to accumulate mutations which give it an advantage, an evolutionary advantage, make them more transmissible, easier to spread, etc. So this is why it's important to track and to study these systematically. We're now performing a risk assessment for these variants of concern. So there's a group, that's the Virus Evolution Working Group that's been set up. There's a network of COVID-19 reference laboratories, 26 labs across the world, and expert groups that are coming together now to look at what does this mean, what studies need to be done, and how do we actually tackle the findings that come out of some of these studies, and what does it mean for vaccine deployment, for example. A few words on the ACT Accelerator, which is an integrated solution to end the pandemic, to get the new tools that are needed. So this was set up in April 2020. You can see all the partners, all the big global health agencies, you know, public-private partnerships, philanthropies, working with government, civil society, industry, to accelerate the development of new tools, so diagnostics, drugs, and vaccines, but also to ensure that we distribute them equally and fairly to people around the world. And the goal was to have 2 billion doses of vaccines distributed by the end of 2021. Therapeutics, you know, the only one that's really proven to be effective so far in reducing mortality is dexamethasone, which is a drug that's been used for a long time. But ensuring that all countries have access to that, as well as the newer therapies. There are lots of clinical trials going on, monoclonal antibodies, as well as other small molecules, new antivirals are being tested. We need to make sure that we can provide access to these. And then diagnostics make a huge difference. There's a real inequity currently in, you know, diagnostics access between low-income and high-income countries, and we need to ensure that, you know, rapid diagnostic tests and the latest diagnostics become available. So these agencies are working together to ensure that these things happen. The COVAX is the vaccines pillar of the ACT Accelerator. It's co-led by Gavi, the Coalition for Epidemic Preparedness and Innovation, CEPI, UNICEF, WHO. And again, it's to both support R&D and manufacturing scale-up of the best vaccine candidates, ensure that as many vaccines as possible actually go through clinical trials, because we do need a broad portfolio, and make sure that we procure at the best possible price, at least 2 billion doses by the end of 21, but then go beyond 21. So it's not set up just for 21 alone, but to ensure that we continue to supply vaccines to those countries who, you know, want to procure from COVAX. Currently, we have 190 countries in COVAX. 92 of them are what we call the AMC countries. So they get vaccines, at a discount or even free. And the rest, 98 are self-financing countries. Those are mostly the high-income countries. As of now, the vaccine landscape looks very good. You can see 170 more, over 170 candidates in preclinical development, so still a lot, and 63 in clinical development. We've had about 8 vaccines where there's some data from phase 3 trials, either through publications or many through only press releases. We're still waiting for publications, and a few that have dropped out of development because they are not so promising in the early stages. So phase 3 trials, of course, are difficult to perform. They need large sample sizes to make sure that we can test efficacy in a robust, double-blind, placebo-controlled, randomized way. Most of these vaccines are 2-dose schedule, are currently mostly intramuscular, though there are a few in development which are nasal vaccines and intradermal vaccines. And there's, of course, the single-dose vaccine from J&J that the results just came out. So it's almost 2 months since countries first started vaccinating. I think UK was the first country to start. Currently, there are about 62 countries. Only 4 of these are low middle income countries. So over 100 million doses of vaccines have been deployed, but most of these in 10 countries. And these are all high income countries, but 7 different vaccines are being used around the world, including Sinopharm and Sinovac from China, the Gamaleya vaccine from Russia, and then, of course, AstraZeneca, the Pfizer, the Moderna. So SAGE is the group that makes policy recommendations to WHO and then to countries through WHO, and they have made recommendations on both the Pfizer vaccine as well as on the Moderna vaccine. So these are available on our website. The idea really is to first prioritize those at highest risk, so healthcare workers and other frontline workers at high risk of getting the infection, and then older people, with or without comorbidities, and then going on to other population groups in order to end transmission. But the first goal is to reduce deaths, reduce mortality due to this infection. So there's a prioritization framework that was developed by SAGE in October, and now they're making recommendations on specific vaccines as the data becomes available. Just a word on the new updates from last week. We had 2 trials that came out with detailed press releases. The Novavax, this is a subunit protein targeting the spike protein with an adjuvant, and they published their data from UK and South Africa. Overall, excellent efficacy, 89%, and 85% against the UK variant, but much less, 49% against a South African variant. So a smaller sub-study that was done in South Africa showed that, but we need to really look at that data much more carefully to see what exactly it's telling us. So it's not that it wasn't efficacious, but there does seem to be reduced efficacy. Similarly, for the J&J vaccine, this is a single-dose vaccine, can be stored in a refrigerator, so it's really easy to deploy, would be ideal, really, in countries if it were shown to have the same kind of long-term protectiveness. Overall, this vaccine was found to be 66% effective at preventing moderate to severe disease after 28 days. And it varied again by geography a little bit. So 72% in the US, 66% in Latin America, 57% in South Africa. So in summary, vaccine development has progressed at an unprecedented speed. Within a year of the discovery of a new virus, we have so many vaccine candidates that are close to completing or have completed clinical trials, encouraging efficacy readouts, particularly from the mRNA vaccines, but also from some of the others. We set the benchmark at 50%. So we said 70% would be desirable, 50% would be the bare minimum for a vaccine to be considered efficacious according to our target product profiles. So all of these vaccines have met that target product profile. We need a lot more data on how long the duration of protection is, what's the optimal gap between doses, etc. We can talk about research priorities. Anna Maria will mention that. But our emphasis right now is on equity, making sure that the high risk and vulnerable groups around the world get access to vaccines at the same time, and that we don't have a situation where the poor countries are waiting for a long time. And this is something that not only countries, but manufacturers and the general public as well really need to come together to have a voice in how this can be done. And the WHO working, with the COVAX facility is doing everything we can to ensure that this happens. So now I'm going to turn it over to Anna Maria to take us through her presentation. I'll stop sharing my screen. And then I think we're going to have question and answers after she's finished her presentation. Anna Maria, over to you.
Thank you, Sumia. Let me try to project my slides now. Oh, okay. Okay. I hope you can see my screen now. Okay, so hello. As Sumia says, we are all working to try to ensure that every person, even the last person in the planet, have access to vaccines that protects them from the associated risk with COVID. So a lot of discussion will come after me about what is being done to deploy the vaccines we have at hand, the ones for which we have results of efficacy and the doses have been produced. But what I want to tell you is that is very good. But in the meantime, WHO and all our partners, we keep working on finding more vaccines, because to reach the last person, we need to have more and perhaps better vaccines. So why is WHO working on this? We are working on this because on the basis of our experience with Ebola, the member states, the 194 member states of WHO felt that it was critical for WHO to use our convening power and our networks to bring all the experts every time there was an epidemic or a pandemic, so that we can conduct the research that is necessary to find diagnostics, vaccines, and therapeutics. And we not only work on COVID, we work on other diseases. As you probably know, about a year ago, we designed a coordinated global research plan that helped us and all the others in the community to move forward with research. And within this coordinated plan, we have a critical pathway for therapeutics. So we look at all the elements from animal models, from prioritization, from what kind of disease, drug we need under the target product profile, and also doing clinical trials like the Solidarity Therapeutics trial. For vaccines, that is our topic today, we did a similar approach. We maintain a landscape of all the vaccines in the pipeline. We have provided the community with criteria so they know exactly what are the ambitions from the public health perspective of the vaccines that we need and should use. And we have worked on the animal models having a say, so when the vaccines are tested, we can compare the results from one study to the next one, and hopefully in the future, evaluate the vaccines using immunological markers through correlation protection. And we also have developed the standards for clinical trials and published them in May. So this is where we are. So as you know, there are lots of good news. We have a number of vaccines who made it to the clinical phase. So they are in phase 1, phase 2, phase 3, 63 of them. We have 174 who are behind in the preclinical phase. They are in animal studies. They are in the laboratory being tested. And hopefully they will move soon to evaluation in humans. Of these vaccines, we have a variety of platforms. We have 4 major groups, as you probably have heard. We have the DNA, RNA vaccines in one group, novel technology, for which we have good results of efficacy. We have the vector-borne vector vaccines. These are the vaccines that are constructed when you use another virus, that is a benign virus, and put the protein of the COVID virus, or the virus we want to be protected against it, inside that benign virus. It's like it's the virus wearing the hat of the other virus we want to be prevented against with. And these vaccines can be replicating or not replicating. We also have the protein fragmented vaccines, that is, you just take the piece of the virus that you think will make your immune system develop a response and use that as a vaccine. And finally, we have more traditional vaccines, the kill vaccines, where you take the virus and in the laboratory you attenuated it in a way that the virus can elicit an immune response but cannot cause the disease any longer. So we have a variety of these vaccines in the pipeline. We also have vaccines that can be administered mostly with injections, intramuscular or subcutaneous, and a handful of them who have the aspiration that could be administered through the respiratory route, or nasal or respiratory delivery. So there is a lot of opportunities there also to look for vaccines with one dose. So you will agree with me by now that we have a lot to do, and we have possibilities among this rich pipeline of finding other vaccines to ensure that we have enough doses of all the vaccines available so every person in the planet can be protected. These are the distribution of the trials. Soumya mentioned that there are 151 clinical trials ongoing. That's good news. Only 20 of them have published the results. Some others have created press releases all around the world, but we need to multiply these efforts. So because of this, WHO has 3 overarching research priorities for this year. These priorities were not invented by us. We have a consultation about 10 days ago where we invited about 2,000 experts from all around the world to debate with us for 6 hours to talk about, okay, what is the priority for this year? And from that, we came up with 3 priorities. The first one is that we need to learn more about the vaccines we have now, the ones that have been deployed. So we need to do a little more of trials, but also as they get deployed, use stringent protocols to evaluate whether or not they have the effect that we anticipate and whether or not they have the impact on the virus transmission that we anticipate and whether or not they are as safe as they were reported in the first trial results that were followed up for some period of time, about 2 months in general. The second part is that we have the new COVID variants. So we have an additional challenge. We have to deal with that. And we need to discuss how we are going to adjust the vaccines as we learn more of the variants, as we learn more about variants of importance for public health. And third one, I already announced, we need to test more vaccines. We need to ensure we have a wider pool of vaccines so more doses are available for everybody in the planet. So on the first priority, we are working on 3 parts to ensure that we address these knowledge gaps of the vaccines for which we already know the efficacy. The first is that we need to ensure there are core protocols and methodologies. Of course, science grows because people have brilliant ideas, alternative ideas, but we need to be sure that there is some commonalities in these ideas, that the designs are equally robust, that the data they are going to generate can be used by regulators and policymakers to make decisions. So there is a list of questions that people will like to know about. For example, how long are the people protected for? Do they need a booster dose or a vaccination each year? We also need to understand how these vaccines induce an immune response, because that will help us to test other vaccines and also to develop correlates of protections. I mentioned the safety. We want to learn more about the long-term safety. And finally, we have recommendations for their deployment. But as we learn more about the disease and more about the effect of vaccines, can we learn how also use the vaccines better as a tool, as part of all the tools we are using? And I want to make now the point that the vaccines are just one additional tool, that all the control measures that have been recommended, social distancing, washing your hands, wearing masks, reducing the number of people you get in contact to, are also non-pharmaceutical vaccines, because the vaccines prevent you from being infected, and all these measures do the same. They prevent you from being sick from COVID. So we are trying to identify what are the key pieces of information from all these studies and maintain a forum at global level where we talk to each other on real-time basis about what we are learning during the use of the vaccines, during the additional studies and the trials, so that we don't miss the collective conscience, but also that the countries that are implementing can learn individually what is happening. In terms of the new variants there are 3 different levels of issues. The first is WHO is working to ensuring that we have better surveillance, that we have even wider capacity at the countries to collect the samples, to test them, to characterize the variants. And thirdly, that once we have the results and a new variant is identified, that we understand if this variant really has an importance for public health, or it's just another mutation in the virus as it transmits from person to person. Because there will be many variants, but only some of them will have public health importance because they will transmit more efficiently, or because it will, for example, change the severity of the disease and make it worse. That's one part. The second part of this is to see what are the implications for public health. So should we adjust some of our measures, including should we consider that some of the treatments we use today are no longer useful, or should we modify the vaccines like we do for influenza every year? Should we collect this information and organize a series of research in animals, in the laboratory, but also in humans, to evaluate and quickly switch the vaccines? So, and who is going to tell this to people? Is every vaccine developer doing it on their own? So what we are proposing is that WHO helps coordinate that, so that we have everybody using the same virus to do the studies, the same approaches to conclude whether or not the vaccine is efficacious in the presence of the variant, etc. That's very important, because otherwise there will be confusion. And then finally, for the new vaccines, we need to do randomized clinical trials. I know that everybody says, but why should I do a trial? Because there are effective vaccines. But that's, you will hear the number of doses available is very limited. In many populations, it will take some time until the vaccines are available to them. And one way to make sure that this time is smaller is testing different vaccines. So we still will need to do randomized trials in areas where the vaccines are not available yet, to ensure that new vaccines come into the pipeline. The second part is we will continue to work on correlates of protection, so measuring what level of antibody titers or types of immune response corresponds to protective levels by the vaccine. That will be a challenge because we are using different kinds of platforms. So it is possible that these correlates of vaccine-induced protection are linked to the platform and unique to each platform of each type of vaccine. Or maybe they are only specific to each vaccine itself. So there are challenges, but the community, the scientific community, is ready to move forward. And then finally, as I mentioned, some of the vaccines in the pipeline had advantages. They maybe need only one dose. Maybe they can be administered without injections. Maybe they induce longer duration of protection. Maybe they are more suitable for certain populations and age groups. So we need to keep working on that. And this new evidence will help WHO issue revised recommendations on the use of additional vaccines. Thank you very much.
Right. Thank you, Dr. Hanal Restrepo and Dr. Swaminathan, for these really informative summaries. We are already getting a lot of questions, and we're gonna take this next bit to do some moderated Q&A. Some of the questions that are coming across are about access to the slides and the video recording for today's session. So please note that following this session, all of the attendees will be receiving an email, and that will include the video, it'll include the session slides and any related resources. So stay tuned for that. Please note also, I failed to mention this earlier, that once you submit a question in the Q&A box, you're gonna notice that it disappears. That's because our ECHO staff are cutting and pasting questions into a live document. And so I'll go ahead and ask the first question. This is from John Overtveit. So considering how widely used now the Pfizer and Moderna and AstraZeneca vaccines are, do we have any evidence yet on the vaccine's effectiveness on reducing transmission?
So maybe the quick answer for that is not yet. There's a little bit of evidence from the AZ trial, which looked at transmission. They were taking swabs every week from the participants and did not show a significant reduction of transmission, but there are studies going on now. Most of these vaccine developers have taken blood samples at different time points, and they can look at antibody levels, which will indicate, infection, natural infection. And so that will tell us, whether they protect against transmission and how much they do. You want to add, Ana Maria?
Yes, I would like to add this to the audience. While this is very important to understand if the vaccines have an effect on transmission, you should be aware that not all vaccines we use successfully today have such effect. So it's a nice to have, but not an absolute requirement. I don't want people to leave the room thinking that this is an absolute requirement. Some vaccines we use today do and some don't. And some of the modelers have started to look into that. And what we have learned from the modeling exercises, when they do assumptions about effect on transmission, is that nonetheless, what is critical is that the majority of the people who are at high risk of the mortality or transmission get vaccinated, regardless of whether or not the vaccine has this added bonus of having an effect on transmission. And the research has been ongoing, but I just want to ensure and insist on people that we are very lucky that we have a handful of vaccines already that have effect on disease, that the severity of the disease is what makes this pandemic remarkably important.
Yeah, very important.
Okay, thank you both, and thank you, John, for the question. I'm going to combine a couple of questions here raised by Hussein Mana and Karen Lewis Bell, and the question is raised about the Johnson & Johnson vaccine when the efficacy is 66%. And then you described other vaccines with efficacy of more than 90%. And really the question is, what is the minimum efficacy that the World Health Organization suggests for the COVID-19 vaccine?
Ana Maria, go ahead.
Thank you. So when we were discussing with the experts back last year and about April or May, we thought, okay, if we have a vaccine that has a 50% efficacy estimated by the trial, and the lower bound, the minimum level of the confidence interval is 30%, we will be very happy. Luckily, the majority of the vaccines, if not all, that have reported the results have these effectives. But I want to say something on top of that. Of course, people say it's very good to have a vaccine with 95% efficacy. Yes, we agree with you, but the efficacy of the vaccine at an individual level is important, but it's not the only thing that counts. What is important is what proportion of the target population also gets vaccinated. So you have 90% efficacy, but only 50% of the population target population vaccinated, you indeed have only 45% of your people being protected against the disease. So it's a combination of that. And the third element that is important is the speed at which we are able to roll out the vaccination. So if I take a year to go through my target population, the effect of vaccination is different than if I do it in a few months.
Okay, thank you. Next question is from Ramon Figueroa. So how can we reconcile the core value of equity and public advocacy with what we're seeing countries actually doing? And they bring up inequities with respect to certain countries predominantly taking up the vaccine to the detriment of poor or small countries. Can you comment on that?
So this is why we set up COVAX, to ensure that we can have this global mechanism to both procure and distribute vaccines to countries all over the world. And we knew that their supply would not meet the demand, especially in the first months of 2021. In fact, we weren't even sure we'd have effective and safe vaccines. But now that we do, it takes time for manufacturing scale up. And so there's going to be limited supplies in the first half of the year and much more in the second half of the year. So we need to ensure that the limited supplies we have get distributed to cover at-risk populations across the world, whether these are healthcare workers or whether these are the elderly and those who are at highest risk of dying, because I think it's important that preventable deaths have to be avoided, wherever you live in the world. And this is something, which is not only morally and ethically right, but also makes economic sense. Because if you have some countries in the world that are fully protected, 100% of their populations covered, and large parts of the world where the virus is continuing to spread, it's causing, health systems are overwhelmed, people are dying, both due to COVID and other diseases. The economy, the global economy cannot recover. So there have been a lot of calculations and projections done to show that if we don't ensure vaccine equity, the world is going to lose something like $9 trillion. And a lot of that is going to be actually borne by the high-income countries. So it's both moral and ethically right, but also economically makes more sense for high-income and other middle and low-income countries to go about the distribution of vaccines in a fair way. So the next few weeks and months will show, if this, our goal and our aim is going to be successful. And certainly we're putting all our energies into COVAX to make that happen. And it's the good news is that we have secured enough vaccines that we will start rollout in February. And so all countries around the world will start seeing doses, even if they're small volumes, starting from February. So they can start vaccinating their high-risk groups.
Okay, great. Thank you, Dr. Somanathan. Thank you, Ramon, for the question. Over to you, Sanjeev.
Thank you, Matt. So I think we have many questions here. Is equitable distribution possible to everyone in the world? This is Yankee Markham from California, Makpal Okoye from Nigeria, Howard Kunya from Kenya, and then Navrat Singham Janakan from Sri Lanka says, is equitable distribution of vaccines, is it possible, or are we going towards moral failure? I think that the way, many of you could address this question, equity has multiple components to it. One is to access the vaccine. But the other issue is that these vaccines have differential sort of effectiveness for what we would call, symptomatic infection. The issue is, are we going to have a world where the more effective vaccines go to the developed nations, the less effective ones go, and then how are we going to really sort of make sure that the people in the world understand that even the less effective vaccines are actually very effective in preventing severe infection, which is obviously really much more important than just preventing infection. So if you could all just take that question. Soumya, we'll start with you.
Yeah, I think our messaging has to be very clear. And when we say that a vaccine is safe and effective, that means it's passed the benchmarks, that we've set globally, WHO as well as regulatory agencies. And that means that it's useful and it should be used. Now, most of the vaccines, or almost all of them that have been deployed so far, have prevented severe illness, hospitalization, and death. So I think that's a really positive, and we need to highlight that. There may be variations, but again, there are advantages to some vaccines over others. So you may have a vaccine with 95% efficacy, but it requires ultra cold chain storage. It requires 2 doses. And if you don't keep those vaccines properly, we don't know if the efficacy is going to remain the same, whereas another one that can be stored in a refrigerator, and that needs a single dose, is effective with a single dose, certainly, makes a huge difference to population. So we have to consider all the different elements and provide reassurance. I think scientists, doctors, community leaders, we need to be saying, and of course, political leaders, saying, not casting doubt or comparing vaccines to each other, but saying, let's get these safe and effective vaccines out there, and let's try to ramp up vaccination programs in as many countries as possible, as quickly as possible.
I would like to add to what Soumya says, that one thing that is not obvious in your question is the fact that the vaccines are just an additional tool. So the question of control and reducing the risk of COVID includes vaccines, but it's not only related to vaccines. And Sumia's point about the vaccine efficacy reported in the trial being only one element of the potential of a vaccine to contribute to the control of the disease is critical. So calling a vaccine better or worse on the basis of the reported efficacy of a trial will be a disservice to the public health control efforts, because what will put the disease down is a combination of all the efforts and a concerted effort in every locality, in every place, to ensure that each chain of transmission is interrupted with pharmaceutical and non-pharmaceutical measures. That's what will bring equity, that we put all our efforts in interrupting the chains of transmission with the tools at hand for us, including the vaccines.
So one of the questions from China, from Afoka Boang Bryce Maxime, is will the vaccine be free to everyone everywhere when it comes through COVAX facility, for example? And then what's going to be your mechanism for deciding which country gets how much of the COVAX allocation? Soumya?
I think some of these issues are going to be discussed by subsequent speakers on the allocation, on the access. You know, we have people from Gavi and we have people who are looking at, Anne is looking at the country deployment. So why don't we take some of these broader questions after the other presentations and focus only on the R&D now?
Thank you. Over to you, Matt.
Okay, thank you, everyone. So our next set of presentations are from Dr. Anne Lindstrand, Dr. Richard Mihigo, and Sani Wendis. And we'll start with Dr. Lindstrand, who is the unit lead of the World Health Organization expanded program on immunization. Prior to joining the World Health Organization, Anne was the program manager for the National Immunization Program in Sweden and NITAG chair at the Public Health Agency of Sweden. For over 25 years, Anne has been a lecturer in global child health, mainly focusing on maternal and child health, humanitarian aid, and vaccines, vaccinology. So over to you, Dr. Lindstrand. Thank you.
Thanks a million, and thank you for showing the slides. Delighted to speak to you today. My internet is a bit wobbly, so I have backup with my colleague, Richard Mihigo, if I suddenly just get bounced off. But next slide. So one of my tasks now at WHO is working within the COVAX to try and support countries in the deployment of these vaccines. And this slide shows us just the speed and the scale that we will see these vaccines being implemented across the world. The complexity of accessing and deployment of these vaccines globally can never be underestimated. You can see that this is a chart from 1990 to now, with all the other vaccines within the EPI program being implemented in countries. And the only one looking a bit like the same is IPV, so the polio vaccine. But here we see that all countries, hopefully, will get access to this vaccine in a very, very short timeline. And the questions that you put forward in the last session is exactly what we do worry about. The COVID-19 pandemic is more than a global health crisis. It's really an economic crisis, humanitarian crisis, security crisis, and human rights crisis. It has disrupted billions of people's lives and our families, and disrupted the global economy. So it really is concerning. All actors, UN included, are very much concerned about the impact, particularly on the most vulnerable populations, migrants, refugees, women, children, older people, people with disabilities, and not the least in low-income countries where you have the weakest systems and maybe fragile countries affected by conflict. And so the way that we can overcome this crisis is really by working together towards science, demonstrate unity, demonstrate solidarity, and support the implementation for all people of these different vaccines. I don't know if, since a very long time, the world hasn't been facing such a big public health effort, and the vaccines will hopefully be instrumental in getting us back to our normal life. So next slide. Here is the latest data from the One World in Data about the vaccine rollout. And Dr. Soumya was explaining before about the speed, and that the vaccine is already being implemented in many countries across the world. About 100 million doses has been administered so far. And on the map you see on the left, you see the doses administered per 100 people across the world. And on the right, you see those countries which have reached the highest number of doses administered per 100 people. And if you look closely, you can see that both on the map and on the chart, of course, these doses have been rolled out for a majority of cases into the global north that have secured large quantities of approved vaccines and started to vaccinate their population. Our DG in WHO calls this a catastrophic moral failure. And I'm proud to be WHO when he actually speaks the truth. Unfortunately, because the global south, now with the majority of people living, has not been having the same advantage as the global north. There is a sharp and high problematic vaccine gap dividend between richer and poorer, and leaving the big bulk of populations out without vaccines so far. The richer countries, of course, they are under big pressure from their populations to reach the political pressure from their own populations to rapidly end the pandemic for them. But as Soumya and Maria
I think we've lost Dr. Lindstrom. I was wondering if your substitute speaker can pick up from here. I'm not sure. Go ahead, please. Would you like to take it from here?
Yeah.
Yeah, Dr. Mihigo? Yeah, go ahead.
Yes, thank you very much. So I think we can move to the next slide, please. So on the next slide, after what Anna has just explained in terms of disparity, in terms of vaccine introduction and implementation between the global north and the global south, the COVAX facility, as has been explained by Dr. Soumya, is actually an initiative that is aimed at bridging this equity gap between the global north and global south, and meant to provide vaccines to a broad range of countries.
So,
and is back.
Richard.
Go ahead, Anne.
Yes, go ahead.
I think she's frozen again, looks like. Please going, Dr. Mihigo. Please keep going, Dr. Mihigo. Yeah.
Okay. So as I was explaining COVAX facility, we have heard from the introductory presentation done by Dr. Soumya is a mechanism that is trying to facilitate.
So sorry, Richard, thank you for stepping in.
Okay.
Okay, I think we are going to text Anne so that we let you do it. Dr. Mihigo, please go ahead.
Okay.
Please go ahead.
All right, so third, I hope this is the right time now. So Anna, I think you are back, but I think your microphone is your connection.
I'm back. We restarted the internet. I'm so
okay,
sorry.
Let's give you the last chance. Okay, over to you.
Okay, we'll give you the last chance. Otherwise, you take over. So the solution, as Dr. Soumya was saying, to be able to have at least one equitable distribution for vaccines reaching everyone was the setup of the COVAX vaccine facility. And here you can see in green the secured doses reaching up to a large part of populations, both in AMC 92 countries and also self-financing countries. 190 countries have signed up for the COVAX facility, which is fantastic. And you can see the rollout is starting already in February and maximizing up month by month until reaching about 2.3 billion doses by the end of 2021. So next slide. In waiting for the supply, countries with the support of regions and headquarters have been, can you show the next slide, please? Can you show the next slide, please? Do you hear me?
Yes. We can hear you, Anne. All right, Dr. Mehigo, please take over.
Okay, so maybe if you can go one slide back. Really sorry about this, colleague. So to support the distribution of the vaccines through the COVAX mechanism, WHO, working with different partners, have put together all the necessary tools to support the proper implementation of the vaccine. Most of the countries, at least all the countries supported through the initiative, have received the guidance and the tools to develop their national deployment and vaccination plans, but also a certain number of additional tools that are helping countries really to make sure that their readiness when it comes to introduce this vaccine is properly implemented. Next slide. So one of the really key elements that and tool that is helping country to not only first attract their preparation, but will be a critical document to help the allocation of the vaccine to all COVAX supported countries is the National Deployment and Vaccination Plan. Most of the COVAX facility supported countries have been requested to develop this important planning and implementation tool, which is meant really to go up to the lowest level possible in terms of preparing the country for implementation. There are several steps that countries are taking to make sure that they can be ready up to when the vaccine will be shipped to their countries. So at WHO, we have started the process of setting up a committee that is helping countries in reviewing first of all, even pre-reviewing those plans, and then secondly, reviewing really the adequacy and accuracy, robustness of the different plans that have been developed. So far, we have 17 countries that have submitted not only their full review, their full national deployment and vaccination plan. And recently, through an initiative that was launched by the COVAX Secretariat to introduce as a first wave the Pfizer vaccine in different countries, we received close to 70 applications in that process. Next slide, please.
Richard, if you want me to take over, it seems like it's more stable now. Do you want me?
Okay, go ahead.
If you give me a last chance. Because this is an allocation. You had questions before about the allocation rounds. And so in the COVAX facility, there has been a process since the beginning of January trying to support countries getting doses as fast as possible. And this was with the first regulatory approved vaccine, Pfizer vaccine, which is a complex, operationally complex vaccine to roll out. It requires very cold storage, specific syringes, diluents that are specific, etc. Anyway, there was a high interest after a letter was sent out from the COVAX facility. 72 countries asked to be part of this first wave, as it was called. And actually not the 29th, it went out the 30th, this Saturday, a letter to all countries, not just those who have raised their hand to implement the first wave, but to all COVAX facility participants. With, first of all, the countries, the 18 that was finally chosen based on risk for disease and transmission, and also seen as ready to be able to roll out this complex vaccine. And then also an indicative allocation for the AstraZeneca doses. Of course, this is pending that the regulatory approval of EUL for AstraZeneca will be working. Now, these 18 countries will have to sign indemnification and liability. There are special Pfizer requirements. They need to get regulatory approval. And then the first doses will then start to roll out by mid-February to end February or beginning of March, depending on when these national allocations will be going down. And then soon after that, we're ready for the next allocation rounds coming up. The first deadline for all countries is the 9th of February to send in, as Richard was telling, the national deployment and vaccination plans. Next slide. And in the waiting, there's been massive training efforts. There are modules up both on how to write and plan for the deployment with thousands of enrollments, and also trainings very particularly about the COVID-19 vaccine for healthcare workers. These are all you can find them on openwho.org, and they're translated in all these country languages that you see below. Next slide. And finally, I just wanted to show you this. There is a website with all the guidance and tools, which spans everything from, as I showed, how to write your national deployment and vaccination plan, to supply chain planification, and to how to engage with communities, which is vastly important. We need communities to trust and want to come up for vaccination. And then there's an email address here if there are any queries or questions from countries. So this is the last slide I have. And then I leave over to Richard again to continue your presentation, not just mine.
Please go ahead, Richard. Yeah.
Okay, thank you very much, Anne, and thank you, our colleague. I hope I will get more chance for the internet connection. Really thank you, and a pleasure to join this group to share the perspective from the African region. I believe the topic and objective of this webinar is really mainly talking to a region like the African continent, where we will see that the rollout of COVID-19 vaccine is still really lagging behind. So let me start by just give you an idea on which countries so far have introduced the vaccine. As we have seen in the introductory presentation from Dr. Sumia, we are more than 60 countries that have introduced the vaccine, close to 100 million doses that have been provided. And when we looked at the African continent, only so far 5 countries have so far introduced the vaccine. And these are really at a very preliminary level. Several other countries are trying to strike bilateral agreements, but vaccination has not really started. So if we talk really about equity, if we talk really about equitable distribution, I think this is the place where really we believe this narrative has got all its meaning. We have seen pretty much a similar slide that was presented by my colleague Anne Lindstrad, but we've tried now to extract only data from the African continent. We are expecting to deploy through the COVAX facility close to 600 million doses, if everything goes well, up to the end of 2021. The first dose are expected to start be rolled out this month. And as you can see on this bar chart, it is planned that we are going to have an incremental increase of the number of doses that are going to be rolled out in the region to reach the maximum of 600 million doses. That is estimated to cover close to 20% of the population. And now the question really arises, what will happen for the remaining 80% of the people who are not covered or, yes, covered by the COVAX facility dose? So in parallel to the COVAX facility, the African Union has launched also an initiative called AVAP, which is the African Vaccine Acquisition Task Team, that is trying also to see how to complement the work that COVAX is going to do to provide up to 20% of the vaccine dose on the African continent. And the objective is to bring the coverage up to 60% by the end of 2021. So far, on top of these 600 million that are going to be mobilized by the COVAX facility, the AVAT initiative has so far made a commitment and deals to raise up to 670 million additional doses. So this will at least bring the region almost close to 50% of coverage, if indeed everything goes well as planned. So to support country to make sure that they are all ready to deploy this vaccine, and even the fewer doses that will become available, we have set up a regional task force to coordinate all the regional efforts to make sure that a country are ready and prepare for the delivery of the vaccine. This is really a multi-stakeholder platform that brings not only WHO and UNICEF, Gavi, who are the traditional partners that are supporting countries for vaccine rollout, but we've extended this stakeholder platform to other important partners like the Africa CDC, the World Bank Group, the African Development Bank, some bilaterals like the US CDC, DFID, USAID, to make sure that we maximize all the supports that country will need to roll out this vaccine. So we have not only the partners, but we have also academicians, regional technical advisory group that are part of this platform. So to measure the country readiness and to make sure that we have an idea of what is going on in the country, we put together a live dashboard called the Vaccine Introduction Readiness Assessment Tool, or VIRAT in short, that is helping us to track progress in each of these different countries. So though the overall weighted readiness score for the region might look lower, 44% as of end of January, we are currently working on with countries to make sure that the information and the data that is uploaded in the tool reflect really the true preparedness on the ground. So we are following 10 key components that will help country to roll out efficiently the vaccine, starting by planning, regulatory preparedness, to make sure that the priority group are targeted and prioritized, the training, logistics, etc. So when we looked at now a more detailed readiness country by country, we have tried to use a sort of a traffic light approach, where the green bar represents activities or steps that have been completed. the yellow ones, those who are in progress, and then the purple, where the progress is slow, and the reds, where activity have not yet started. So if you can see on this bar charts, countries are at a different stage of preparation. And then when we looked at the readiness pillar one by one, we can see that the different 10 pillars that we are following are not at the same level indeed. If we looked, for instance, the training, monitoring, and evaluation and supervision, which are supposed to be really the last steps before a country introduces the vaccine. Of course, most of the countries have put in place the tools, the materials for training, but the actual training has not yet started because the country so far, up to yet actually this weekend, we're not even aware of which type of vaccine they are going to receive. But there was a big announcement that was done over the weekend where all the countries in the region received a notification from the COVAX Facility Secretariat on the potential number of doses they are going to get as a first installment, as well as the country that are going to introduce the Pfizer vaccine as the first wave. So this was really a major development over the weekend in the region. So to conclude, what are the challenges that some of the countries are facing? It's the use of, for instance, the non-WHO EUL recommended vaccine, the emergency use listing being a process by which emergency authorization is given to some of the candidate vaccine, of course, after review of the safety and efficacy of the data, but not necessarily the full pre-qualification process. So I think this has created some challenges, and countries are not used to this type of approach. We are working quite hard, even for those who have chosen to introduce these vaccines, to provide the necessary support to make sure that everything will go well. The issue related to vaccine indemnity and legislation has been one of the quite critical issues that the country has to go through, because for these new products, manufacturers are requiring that country sign some indemnification and liability document, which is not common practice indeed during routine immunization process. Resource mobilization to make sure that the implementation will goes well, while the COVAX is providing vaccine and to some extent some resources to roll out the vaccine. Countries are still coming up with a financial gap to make sure that they are going to meet all the costs related to vaccine implementation. And then finally, the delayed VIRAT update to reflect the reality on the ground. I think we are working closely with the country to make sure that data, information they are entering in this VIRAT tool, which is a live dashboard, do reflect indeed the country preparedness on the ground, so that we may not give the false impression that the region is not ready for the introduction, knowing very well that there is a wealth of experience in most of the country for the introduction of new vaccine. So what are the next steps? We are working hard to support country, particularly those who have decided to introduce non-WHO EUL vaccine, to manage all of these aspects, being the regulatory aspect, pharmacovigilance, and safety, service delivery aspect. We are currently really working with countries to review their national deployment and vaccination plan, which are important documents that will trigger, by the way, the release of the vaccine from the COVAX facility. And as part of the first wave countries that are going to introduce the Pfizer vaccine soon, these are the 3 countries in the region. We are also working hard to support them. Most of them have got the ultra cold chain capacity to roll out this vaccine. We would like just to make sure that we have put in place a learning agenda that we are going to pick experience from those 3 countries so that it can be disseminated in other countries. On top of what we saw during the Ebola vaccine, that, by the way, used the same ultra cold chain vaccination in responding to the outbreak in DRC and neighboring country. And then finally, as part of this objective of this webinar, to continue to advocate for equitable vaccine distribution across all the countries. Thank you very much.
Thank you. Please go ahead, Dr. Vendis, with your presentation. Thank you.
Thank you very much. Let me see if I can share my screen. So first of all, I would be proud to be able to call myself a doctor, but unfortunately I'm not. But let me see, are you able to see my screen?
Yes.
Do you see the presentation or do you see a Gavi logo?
I see Gavi, ECHO, World Health Organization on the first slide, yeah.
Okay, and good. Okay, I just wanted to make sure that, let me get it up in presentation mode. Here we go. All right, good. Do you see it now or do you see it in presentation mode?
Presentation mode is perfect.
Okay, good. Perfect. Well, thank you very much. And I know that we're running a bit late on time, so I'll try to be quite succinct in this. And first of all, I'm really happy to see that we're so closely aligned with our partners on this, because a few of the slides that I was expecting to present on and Richard just went through, so that will help us to move this on rather quickly. But we've seen this before, both in Sumia's and in Anne's presentation, but the goal of the COVAX facility is to ensure that we have doses available for at least 20% of the world population, of countries' populations. This translates into a goal immediately of having 2 billion doses by the end of 2021. And we just did see a second ago what that distribution will look like, and We'll also look at that in a second. How do we do that? We do that by focusing on a portfolio of different vaccines, so that we make sure that we do invest in the vaccines that have the most promise, and so that we're able to distribute the ones that are proving to be successful and come through the system. What we want to ensure with that is that we're able to deliver these vaccines as soon as they become available. So as soon as they get regulatory approval, we want to make sure that we can make them available to the world at an equal pace. And I think this is something that's very important and that we've also spoken about, but it is the equitable rollout, which means that the goal that we have for ourselves is that all countries should get access to the vaccines at the same time through the COVAX facility. This will help us to end the acute phase of the pandemic, and then very rapidly, hopefully, help us to rebuild our economies and our societies following this. Now, this has been done, or is being done, through an unprecedented collaboration, I would have to say, in the global health landscape. You have on the bottom side, you have the 3 organizations that are part of the COVAX pillar, which is CEPI investing in the R&D in the vaccines, WHO responsible for the regulatory approval and the readiness and the allocation, and Gavi procuring the vaccines and getting those out to countries at this equal pace. And it is a very true partnership that's happening. And as part of that, you'll have the Office of the COVAX Facility, which was established within Gavi to be the procurement mechanism, the global procurement mechanism to help bring these vaccines through. So it's an office that's set up within Gavi, which has a very large experience with the distribution and the procurement of vaccines. And what's new about this as well is that it is a global reach. So we're talking a lot today about what we call the AMC participants, which are the funded participants that will have access to the doses through this mechanism through donor-funded funds. But you also have many self-financing participants that have signed up to be able to buy their vaccines through the COVAX facility. Now, this is within the governance of the COVAX, and I won't go into a lot of detail on this, except to show that on your left-hand side, you can see that we've set up a number of mechanisms that ensure that the countries are part of of rolling this out and that are part of the decision making around the whole processes which are governed by the Gavi board, but where we get input from the countries that are part of the mechanism as well. And then we spoke briefly about the allocation mechanism, and Anne spoke about this as well, that we have an allocation mechanism that has been put in place and that is being supported and validated by an independent allocation validation group of independent experts that help us validate what the allocation should be to each of these countries as per the allocation model that is set up. So this is a bit about how the whole facility is being set up to be able to deliver on our promises of delivering 2 million doses. Very importantly is below the office of the COVAX facility is what we call our procurement coordinator, which is UNICEF and PAHO as well in this case, to be able to help us procure the vaccine. Now, moving on to what does this look like? And sometimes it's help. We've heard about the 101 confirmed and eligible participants, but sometimes it actually helps to put them up on a map. And as you can see here, the COVAX facility really is having a global reach. These are the countries that are both the AMC 92, as we call them, countries, which will have access through the donor-funded doses, but also the self-financing, self-procuring countries, which are, as you can see in red. So a truly global initiative through this mechanism. Now, if we look at, and this is the slide that Anne had as well in her slide deck, and happy to see that we're very aligned on these, is that we're looking at a very rapid scale up and rollout of the vaccines during the duration of 2021, with doses rolling already in February. And then, as you can see, a steady increase in those doses as we move along. The allocation of these and the timings of these will be decided through the allocation model. And as we said, it's very important to note that countries will attempt to roll them out in all countries at the same time to ensure that it is equitable access and we cover healthcare workers first, risk populations first, and then gradually increase the number and the coverage of the populations. Now, the last slide that I had planned was one that we've actually already seen before, which I think is a very important one, which shows what are the steps that are important to bring out. And so both Richard and Anne spoke of letters that went out over this weekend, giving what we call an indicative allocation. How many doses can a country expect to receive during the first 6 months? But all of this is dependent on many of these steps actually being put in place, as well as ensuring that the global supply and the supply of the agreements that we have are able to be delivered. But it's very important that we now work together globally to ensure that the vaccine deployment, the national vaccine deployment vaccine plans are submitted, are reviewed, country readiness is assessed, and we work together with countries to be able to ensure that as soon as these vaccines are available, we can deploy them into the countries and make sure that they actually reach the population groups that need them as quickly as possible. So let me stop here, realizing that we are a bit over time and wanting to leave some time for questions as well. So with that, over to you, Sanjeev. Thank you.
Thank you. Thank you for that great talk. Yeah, I think we'll probably have time for 1 or 2 questions only. So the first question has to do with this issue of, there was an article in The Economist which basically said that the current rate, including the COVAX facility, it would take up to 2025 to vaccinate most people in the world. So the question, and of course, there is the AstraZeneca vaccine, there is some donor procured vaccines. What is the potential for actually taking the vaccines, for example, Pfizer or Moderna vaccine, and actually put that into generic manufacturing so that we can actually change this timeline? It's such a beautiful effort that you all have, but still compared to what is required with 7.3 billion people in the world, we need a lot more. And I think that's the one question. Linked to that is this issue of, will everybody in the COVAX facility get the vaccine for free for the countries? And related to that, the question, and I'm not taking people's names because lots of people have the same question, is this issue of what is the formula for sending out 2.2 billion doses? Who gets more, depending on what? Is it population-based, income-based? What's going on there? If you could just, all of you have, and whoever feels more qualified, please take the question, please. Starting with Sana. Okay, go ahead, please.
Thank you.
Yeah,
So, right, I'd love to leave the questions around the allocation piece that Anne can speak to that in terms of how that is set up. So the COVAX facility doses for that, what we call AMC 92 countries, are doses that will be delivered for free for these countries. So that is one thing that I did want to clarify. In terms of the supply forecast that we saw right now, and to your first question about the current rate, I think the first presentation we saw from Soumya as well was showing that there are an increasing number of vaccines that are expected to come through the pipeline as well. So this supply that you're seeing right now is the supply of which we have agreements of approved vaccines that are coming through as we speak right now. But we are expecting that as vaccines will come through, that the supply of those will increase quite substantially to be able to meet this need much quicker than by the dates that you were saying of 2025. So with that, I think that let me hand over to Anne to respond to the questions around the allocation. Thank you.
Yes, and first to say that there are great efforts right now in discussions between Gavi, WHO, and many of the high-income countries about dose sharing. So those deals with countries who've made deals way beyond their needs, multiple times their populations, there are discussions about sharing those excess doses and put them through the COVAX facility for being shared much quicker. And so those negotiations are advancing. They're tricky, but we hope that the world's richer leaders, political leaders, will respond to that ask and request because we need to share the doses equally for all countries and all populations. So the end number of doses that we've shown today is not the final ones that probably will be distributed through COVAX. Richard was also telling about other initiatives, which are the AU, African Union, where there will be many, many 100 million doses as well, additionally distributed. And the manufacturers are doing their parts of increasing the manufacturing size and the number of doses, but it is tricky. It is tricky to quickly ramp up production as they are requested to do right now. When it comes to the allocation mechanism, so the allocation mechanism is set up to be a very equal process. It's a allocation mechanism that takes into account a few parameters of the preference of countries. So if they want to have 1 or 2 vaccines, if they want a specific vaccine, or they definitely don't want one set. So you come in with a certain set of principles. And then it is really an equal distribution across the 190, depending on volumes of populations in countries. So the number of doses coming out depends on the total population size of the countries. That's the short story.
Thank you very much. I think we are running out of time, so I would like to bring this session to a close. Thank you for this extraordinarily, I want to thank all of you speakers for this extraordinary session. And I want to thank you for all the learners for attending the Global Learning Collaborative. And we have another session on March 1st on Global Learning Collaborative on COVID-19 diagnostics. I hope you can join this. For anyone who wants continuing medical education credit, it's available. There's a link in the chat. And I just want to, all of you, the WHO and the COVAX facility from the side of our Worldwide ECHO network, where we have 1.3 million learners on the network. we want to offer our assistance to all of you for workforce training and disseminating of your best practices to tackle this issue. Please reach out to us anytime you need help. And thank you so much for your continued interest in Project ECHO's special programming. And be safe and have a wonderful day. Bye-bye.